Hello, my name is Niall McKay and welcome to Living with PSC, a podcast about the rare disease of primary sclerosing cholangitis. Now, PSC causes the bile ducts inside and outside the liver to become scarred, narrowed and eventually blocked, and leads to liver cirrhosis. In this podcast, we aim to dispel some of the myths about the disease. So I'm here with Dr. Lazaridis, who is an expert in genetics and also in PSC. Dr. Lazaridis, do you want to just sort of give us your qualification, if you like?
My name is Konstantinos Lazaridis. I'm a hepatologist here at the Mayo Clinic in Rochester, Minnesota. My training it's very diverse. Starts with internal medicine, then with gastroenterology, followed by genetics, and one of my main focus of my research is primary sclerosing cholangitis, PSC.
And have you been able to find a genetic link to PSC?
There is a range of genetic diseases, correct? The classical genetic diseases where there is a single mutation of a particular gene or mutations of a gene that can explain the disease. For example, cystic fibrosis is one of those paradigms. And then we have diseases such as primary sclerosing cholangitis, inflammatory bowel disease, type 2 diabetes, where there are multiple genes contributing to disease. And for the most part, those diseases, they don't have a specific mutation, but they have multiple genetic factors, which we call them susceptibility genes. And so you may have this susceptibility gene and you may develop disease, but also there's a good chance that if you have it, you may not develop the disease. And so that is the challenge, and that's why we call those diseases complex diseases genetically, such as PSC. Yet, doing genetics work in that space helps us better understand the landscape of genetics and the correlation with other diseases. And hopefully, one day, having this information will be in a better way to interpret what this means for the individual. And we may have some ways of predicting the development or the outcome of disease using some of the genetic information.
So you might be able to, for example, say, because I believe there's other factors such as environmental factors that contribute to it. Also, probably behavioral factors, perhaps.
Yeah, I would call more. It's very difficult for me to conceive a behavioral factor right now for this disease, but clearly I can see the environmental component to it.
And what would the environmental components? I mean, can you explain that a little bit closer?
Yeah, sure. So as you realize, others and us, we have done a lot of work in the genetics in the last 10 years, and now naturally we're moving to the environmental exposures because we have all those biospecimens from these participants with disease. Therefore, it's natural for us to go to that space because one of our hopes is that it's not the genetics or the environment per se, but it's rather the interaction of those two elements that come together to participate in the development of the disease. We have done previous work by asking individuals to tell us about environmental exposures. We published on this, and we found very little. Mm-hmm. Actually, one of the most interesting things to me that we found is that there are some exposures that protect from PSC. Well, I will put it differently. There are some exposures that associate with less development of PSC or less evidence of PSC. For example, people who have PSC, they drink less coffee, and to me that's an environmental, you can call it a behavioral element too. Why this happens, we don't know, but that's an observation that we and others made, and I think may have to be a component of the disease development. As we speak, we're doing a fair amount of work to understand exposures um, um, from the environment, because when you ask exposures based on questionnaire data, you are driven by bias in memory, and it's better to have ways to test people by doing direct work on biospecimens, and that's what we're doing right now.
I see. And smoking as well, right? People who smoke are less prevalent. Not that it's a good reason to start
Yeah,
smoking, but
that's correct. That's correct. And again, we found these two, but again, this is known for some time. So clearly, those there are some studies there indicating that the environmental exposure it's there and it contributes, and maybe contributes more than the genetics actually. But I don't think the environment alone or the genetics alone are the ones that are going to explain the vast majority of the disease for these patients, but rather the interaction.
and presumably this is not just that they die earlier from heart disease or cancer, for lung cancer,
Yeah,
uh, but presumably, would there be, because one of the things that seems to keep coming up is this idea of the microbiome or the bacteria in our body, or more particularly in our stomachs, having an
yeah,
effect on the illness.
yeah.
Would there be a crossover between that, say, and possibly coffee,
Yeah,
nicotine?
so I agree with you. The microbiome is a very important element, and we're doing studies actually as we speak to understand this better. But we have also to realize that the microbiome that we all have is influenced by what we drink and eat and exposed to. And so that's why I said exposures are very important. The medium that these exposures may affect uh, our systems or the microbiome, it may be the stools that is a medium, or maybe other things that we don't know.
I see. And in terms of, say, for example, people with complete vegetarian diets, are those factors in it?
Well, as we did have a paper published from our questionnaire data, and we found that people who have PSC usually they have a more westernized diet and less a vegetarian diet. So they eat more meat, they eat more red meat, they eat less seafood, at least in the U.S. population. And so there are some indices there that types of food may associate with this disease.
There was some studies done with sort of green vegetables and how they affect the illness.
Yeah. Again, we need to do more about the environment and the exposures. I mean, that's my opinion. At the same time, uh, my own belief is that the environmental exposures that may be important for this disease, they're going to be something very common in the environment. I don't think it will be a specific toxin that it happens to be in one in selected areas, on a geographic domain. But I would rather find that most of those things are probably exposures that are very common, household exposures that we see every day in our food, rather than toxic elements being in some areas that unfortunately those people they go there and they expose and that's they develop the disease. And we have some evidence for that already by doing work in that space, but we have to verify and publish before we can talk about it. All I'm trying to say is that those exposures that we think are critical for the disease development are most likely going to be common exposures that we have in our daily lives. I don't anticipate to be toxic exposures in a particular geographic location that expose a few people, and those then become develop PSC.
So what you're saying is that you kind of suspect that, if you have the genes that predispose you to the illness,
That's correct.
and if, for example, you eat a certain type of meat that maybe has a certain type of antibiotic with it, that it reacts with your microbiome in a certain
Yeah,
way.
it's a plausible possibility. Yeah,
Yeah.
yeah. Or if you use some healthcare products commonly, and you have the uh, genetic profile of a certain type, which may be activated by those products, and then this creates a cascade of events in your immune system that somehow target your liver cells. Maybe because this substance is metabolized and in the liver, which many do, or for other reasons that we don't know. Uh, as a matter of fact, we just got funding from the NIH to study a number of those elements, and I'm going to have a press release on that. So, major funding from the NIH to study um, the genetics and environmental interactions, how they contribute to the development and the outcomes of PSC. And this is a study that involves uh, four groups. It's our colleagues from Norway, Tom Carlson and his group, us here, from Mayo Clinic, and the North America. I mean, well, I would say for the most part, is Mayo Clinic for those patients. And then we have the University of Emory University from Atlanta, who is helping us with the environmental exposures and the metabolomics. And we have the University of Illinois Urbana-Champaign, who they help us with artificial intelligence systems and computing to put all these elements together to have some meaningful outcomes and findings. And in this study, we're going to evaluate about 1,000 plus people with PSC and another 3,000 people with different uh, categories, so we can understand um, um, again those elements and how they play in the disease development.
And is it more likely or less likely that we're talking about toxins or about microbiome or both?
I think it will be both. In my opinion, I think the microbiome is there and will stay there. Um, and I believe the microbiome is modulated or is affected by a number of elements. This can be food, this can be exposures. So to me, the microbiome is it's like looking like it's another medium. So if you collect blood, you can analyze the blood for exposures, correct, and it can tell you
Mhm.
something. Microbiome may tell you the same thing probably as another signature of the disease. So I see it as a medium that contributes to the picture.
So it sounds like, I mean, can you see a point in the future? Because at the moment, and when any PSC patient rolls into a doctor's surgery and they're told, there's no cure, but the treatment is a liver
Yeah,
transplant,
yeah.
it's kind of a scary prospect. But do you think there is a time, that we're looking at that we'll be able to manage the illness outside of liver transplant?
Yeah, that's our hope, correct? I mean, we hope to have this available at some point. Um, so if we understand better the disease, I think that's the hope. We'll be able to make better predictions and provide novel therapies for the disease. So if we think an exposure is contributory, then we try to say to people, try to avoid exposing yourself from those elements. Or if you are exposed, well, how can we reverse this process, even before you develop the end stage disease? Because I think by the time we have end stage disease, we're not today in a position to reverse this process.
I understand. Do you see red meat as a factor in that? Would you? Would
Well,
you?
as I
Would
said,
you?
it's based on what we did with this questionnaire data, it's an indirect risk factor. Um, but I cannot make the connection. People,
I see.
people before they define that, they have to make a mechanistic connection how this connects. We say that people with PSC, they eat more meat and they eat less seafood. Now, this is in the US. In Norway, may be a different situation because in Norway they have a lot of seafood. Still, they have PSC.
Yeah.
But definitely in the US population, that was what we observed.
Well, one of the things that seems to be if you are already presenting with the illness, like clearly, um, despite modern preferences for thinking so, sometimes there's no way of eating yourself healthy.
Yeah.
Um, but there does seem to be a way of eating yourself sick.
No,
Would you agree? Do you think
yeah,
that's
I
true?
agree. I agree. I mean, westernized diets are associated with many diseases, and so we have to, be better in that aspect and promote this more.
Do you work mostly on the genetics, or do you also treat patients, PSC
I,
patients?
I, I do both. And as I said, although we have done a lot of work in the genetics, in the next 5 to 10 years, we're going to do work above and beyond genetics, because this is where the field goes. We're going to leverage the genetic knowledge, but what we were able to learn from genetics as we speak, it's for the most part done for now until we go to the next iteration, probably in a few years from now. So the vast majority of the work that we have to do, it's going to be in the post genetic space and leverage the genetic information that we have already in our hands.
I understand. And when you're treating patients, what is like? Do you have a way of treating patients outside of the norm?
No, we usually, we do usually the same, the same clinical assessments as most people do. We like to have more imaging to predict development of cholangiocarcinoma, bile duct cancer. We like to, to develop better tools to understand disease progression. Actually, we're having a paper that's coming out later this month in hepatology where we describe a new clinical tool that we developed based on biochemical markers to predict disease outcome.
Wow.
And actually, I was working on the press release, but just a minute ago, and so we now have 9 variables that we can put in an algorithm, and it can tell you the disease, the rate of disease progression. Not looking at transplant because transplant it can be very tricky as an outcome, but looking more into hepatic decompensation to the point that the liver starts kind of failing. And so we need more tools like that, and that's an area that we like to focus more of our work, um, because everybody with this disease behaves differently, and when we treat people, we need to treat people that they have these similar expected outcome. Because if someone naturally is not going to progress compared to someone else, if you put them in the same trial, your results will be affected and it will be biased. You see my point?
I do, and so many things affect trials.
So that's why this tool that we're developing, and it's called Presto. It will help, at least from the point of disease stratification. It will help stratify patients better prior to trials, and so before you go to trial, you're going to have a percent of um, uh, disease decompensation at 5 years that is given to each individuals based on their profile of these 9 parameters. And in the end of the trial, you'll have an observed number. And if the observed number is better than your estimation at the time of entry, then that will be successful treatment because it seems like it helps. You see my point?
Wow. Yeah, because I mean, obviously, one of the great tools that really harms PSC patients. Well, it doesn't really harm them, but in terms of is the MELD score, right? Because
Say it
it's
again.
really MELD is better for measuring a gradual decline in liver function rather than a sudden decline.
The Presto score that we have is better than MELT actually when we tested it in our group and when we tested with the Norway population. That's part of this publication, the press release, because the MELT score was developed just to assess for liver transplantation, which is a very late stage of the whole disease spectrum. And we need to have things that are earlier in the process. And that's what Presto does. It brings things earlier into the spectrum of disease. And so the predictions are more meaningful in our minds.
And I'm just looking. I just googled as we talked, and I'm on the NCBI here, and the Presto. It's Billy Rubin.
Yeah, that's correct. So we post it out there, and people are going to use it once the publication is out. We did a lot of work. We put it out on the public domain for people to use it, and you can put some anybody's numbers, and you can see what happens whether they have hepatic compensation, because the compensation happens, and then it takes a number of years to develop cirrhosis and develop all this late disease. So as you realize, Presto is in the very early space of the disease, and that's a good thing in our minds. And that genetics things that we do, although we spend a lot of time in the last 10 years, it's a very small portion of what we're doing right now, because we're moving forward, and we want to go fast and unravel other areas and leverage the genetics as we go.
So will this be out? Will this be on your website as a tool,
Yes,
or
yes,
how?
yes. Actually, we're developing a PSC blog through the Mayo Clinic, which is going to bring updates about where we are, and have blogs, and have the scores too that people can use.
This talks about cirrhosis. This tells you where you are in stages of cirrhosis, or
You mean for the Presto? Yeah,
yeah.
it talks about Presto talks about the end point of Presto is hepatic decompensation. So
Okay,
by the time you develop it, probably have cirrhosis. But again, we wanted to take to the way we developed the score was not with people who have end stage disease.
got you. And can we talk? Can we change gears a little bit
Sure.
and talk a little bit about um, uh, bile duct cancer
Yes.
and the relationship? So, is there a section of the, given that not everybody gets bile duct
Yeah, it's
cancer, for
about ten
example,
percent.
about
Yeah.
10%? Okay, yeah. And are there markers that you can tell whether?
Very. There are some markers, but they're not very predictive, and they're not very useful. Unfortunately, we're looking for a better biomarker for cholangiocarcinoma development.
So really, when you're diagnosing bile duct cancer, you're using the imaging
That's
mostly.
correct, and that's correct. And maybe the imaging will be one of the best ways down the road, but that's the only way we have right now to predict this from happening. The other challenge with the bowel duct cancer is that there are very few patients. We understand that this is a very serious diagnosis. Pretty much excludes you in many cases from transplant, and the therapy, with the exception of surgery, which is very limited because of a diseased liver, it's very small. Uh, it's a very tough diagnosis. Well, from the prognosis standpoint. At the same time, it's not an easy diagnosis because the tumor looks like also the scarring tissue of the liver, and so many times it can be missed. Um, the challenge we have with cholangiocarcinoma is that, this is a very rare disease, and then you have an uncommon uh, um, complication which affects about 10% of people, and so even at places like Mayo, where we see a lot of those patients because of protocols we have in that space. And so then we have 10% of something very rare, which makes it very difficult to develop studies around that to look about pathogenesis. You see my point?
I do, yeah, I understand. So, but yeah, and of course, I think in the UK, or in some countries, it automatically precludes you from getting a transplant,
Yeah.
having cancer. Because is there any genetic link between the bile duct cancer and?
People have worked, but there's nothing convincing.
I see.
There's nothing convincing there that there is some work done in non-PSC cholangiocarcinoma, which is another disease, but in PSC there is very little, if any.
And so the figures don't really help us. There's not GT gamma or any of
No,
those things.
no. We don't have a biochemical marker. We have CA99. By the time you know it's high, it's very late in the process of the disease to kind of So the ideal situation was that you get PSC, you have a biomarker, it tells you may develop or not a cholangiocarcinoma. That would be the ideal scenario. So you screen more, you transplant those people probably earlier. But we like this.
Yeah, yeah. I have heard of people that the most accurate way is really to do ERCP and take
Yeah,
a sample.
yeah.
Um,
So probably we need
um,
better imaging tools to understand this development of cholangiocarcinoma earlier in the process of the disease.
I understand. One of the things that I've heard from near every transplant person I've talked to has said that when they got the liver out, that it was in much worse shape than the doctors predicted.
Yeah, that's probably true because by the time we do transplant, those people they have very very advanced disease, and some of them die without the opportunity of transplant.
Yeah,
I think if they were available organs, we would probably transplant more people. This
yeah,
reflects that to some degree.
yeah, yeah, yeah. It would help to have a opt-out system or something like that. Might be useful. Um, well, great. Is there anything that I didn't ask that I should have asked?
Yeah, as I said, there is more work on PSC now for a variety of reasons than before, 20 years ago, 15 years ago. Um, uh, I think patients are more aware about the situations and the condition. They're more eager to participate in studies. Uh, Despite the fact we have a very challenging disease to solve, um, I think that there must be great hope of significant discoveries in the next 5 years. Um, and I strongly believe that it's the interaction of the environment and the genetics that will give us better cues to treat those patients, and it will make an impact because of all the tools we're developing, um, all the understanding that we're getting by understanding genetics and environment and other things that people do. And we now, for the first time, I can talk about our work here. Um, we are investing on this cohort of patients, and we go back to them periodically now to have additional collections. So for the first time, we try to see what happens over time by doing serial collections at different um, systems, the microbiome, the blood, the urine, which is going to be very helpful. And so I think we're developing a lot of data, and we like to have better ways. And I think artificial intelligence in this field, as well as in other places, it will help us to do that.
Great. Well, thank you so much for your help, and I look forward to speaking with you again soon.
Yeah, Neil, thank you for your help here, and thank you for your time.
Okay, take care.
Well, I'm afraid that's all the time we have for this week. For more information about PSC and for a list of people and topics we'll be covering in the near future, please go to www.pscpartners.org. That's www.pscpartners.org. PSC Partners is a non-profit organisation dedicated to providing education and support to primary sclerosing cholangitis patients. There is information and resources on the website. There is a conference once a year. There is a private Facebook group that you can also join. Also, please join our patient registry. This is an anonymous database that provides research support to the medical community who are researching this disease. Thank you very much for listening.